Thanks to all for being here today. I would first like to recognize that I'm presenting today on the unceded traditional territory of the Algonquin people. So while the COVID-19 pandemic has directly or indirectly impacted nearly anyone on the planet, it is undeniable that we are not all equally affected by the virus and by the measures adopted to contain its spread. COVID-19 has intensified vulnerabilities that follow the fault lines of pre-existing and intersecting structural inequities, including those based on race, class, gender, age, and ableism. Hence, while calls for solidarity have insisted that we are all in this together, it is clear that we are not all riding in the same boat. As we argued in the book, the deep inequities that divide our societies are the root cause of our vulnerability to the COVID-19 pandemic. Therefore, a just and sustainable recovery requires our societies to address the persistent injustices that harm us all within and across countries. This presentation will discuss how the different systemic inequities identified in the book intersect to increase the vulnerability of some groups and individuals to COVID-19, as well as to the measures taken by the government to contain the pandemic. I will conclude then with a few thoughts on the path towards a more just and safe post-pandemic future. The chapters in the equity section of the book clearly show how certain populations and individuals, including the elderly, people with disabilities, people living in poverty, women, racialized and indigenous peoples, are disproportionately impacted by the virus, not because of their inherent characteristics or bad choices, but due to pre-existing structural inequities over which they have very limited control. For instance, COVID-19 has flourished in settings where mobility and the possibility for physical distancing is limited or non-existent. In Canada, like in many other countries, COVID-19 is disproportionately affecting people living in long-term care homes, group homes for people with disability, and prisons. As several chapters in the book document, in Canada, the substandard quality of care in many long-term care homes caused by understaffing, low wages, precarious employment, and lack of oversight following years of neoliberal reforms, among other factors, have created a fertile ground for deadly COVID-19 outbreaks. These outbreaks have heavily impacted residents made vulnerable by age and comorbidities, but also their caregivers, who in many settings are predominantly racialized women. Moreover, Canada is like other countries in having failed to protect detained individuals against COVID-19, leading to high rates of infection and death for inmates worldwide. As documented by Professor Adelina Efteni, in Canada, federal prisons, for instance, where at least 5 outbreaks have so far been reported, communal eating, food serving, and group activities have not been suspended in all institutions. Furthermore, incarcerated individuals have often not been provided with individual protective equipment, and prison officers do not invariably wear protective equipment when interacting with prisoners. Instead, many prisons have used isolation more systematically as a response to the pandemic, despite the documented impact of such measures on mental health and their implications for human rights. Since racialized individuals, indigenous people, people living in poverty, and people experiencing homelessness and mental illness are overrepresented in prisons, the failure to protect incarcerated individuals against COVID-19 also disproportionately impact the most marginalized and vulnerable members of our society. Access to a safe space to physically distance or to practice basic protective hygiene is also greatly limited for people living in poverty. Individuals experiencing homelessness, many of whom already face significant health issues that make them vulnerable to complications from COVID-19, often cannot practice physical distancing in shelters, in addition to lacking access to clean water and sanitation facilities. Other people living in poverty often share crowded and poorly ventilated living spaces that prevent physical distancing and isolation in case of infection, putting them at higher risk of contracting the virus. In Canada, as in some other countries, the poorest neighborhoods tend to be populated by racialized individuals, many of them occupying precarious positions as personal support workers, nurses, frontline workers, and slaughterhouse workers, occupations that carry a high risk of exposure to the virus. As documented by several recent reports, Black Canadians in particular are experiencing far worse health outcomes related to COVID-19, which may be explained by the nature of their occupation and their living conditions. Indigenous peoples in Canada and elsewhere also face unique challenges in dealing with COVID-19, due notably to crowded and substandard housing and lack of access to clean water and to adequate health care in many Indigenous communities. While many Indigenous peoples in Canada have taken measures to protect their communities and their members, outbreaks in these communities could have disastrous consequences, as we have sadly learned from the 2009 H1N1 epidemic. In addition to increasing vulnerability to the virus, these multiple, often overlapping sites of oppression are also disproportionately exposing the most marginalized groups and individuals to harms resulting from measures taken by government to contain the pandemic. At the global level, public health interventions such as national lockdowns and mass quarantine measures can have tragic consequences, especially in low-income countries where millions of people live off precarious and often informal employment, in addition to having no access to adequate housing, clean water, individual savings, or social protection, India being a prime example. Even in wealthier countries, lockdown and confinement measures have had significantly heavier impact on people living in poverty and racialized people. Recent studies showing, for example, that Black Canadians and recent immigrants report much more serious financial impacts from COVID-19 than the average Canadian. Lockdown and confinement measures have also exerted increased pressure on women and children victims of domestic violence. So as reported by the media, the situation has been particularly worrisome for Indigenous women and children who live in small and remote communities where safe houses are lacking. Lockdowns have also heavily impacted persons with disabilities who have seen essential programs and services reduced or suspended, as well as people living with addiction who have faced the closure of safe injection sites, leading to sharp increase in overdoses in many Canadian cities. Finally, as documented in the book, racialized people and individuals experiencing homelessness or mental illness have been disproportionately targeted by the policing and enforcement of public health laws. With the closure of shelters and the reduction of their services, many homeless people find themselves with nowhere to go during lockdown. The media have reported that homeless people in some Canadian cities have received very heavy fines for violating physical distancing and other COVID-19 related punitive measures. Studies have shown that in many cities in the world, in fact, discriminatory patterns of policing have been reproduced in the context of COVID. Of a COVID public health directive enforcement, especially against racialized and homeless people. As this example shows, multiple grounds of exclusion and oppression intersect to increase the vulnerability of groups and individuals to the virus and the measures adopted to contain the pandemic. Achieving just and sustainable recovery requires not only that we control the virus and rebuild our economies, but that we do so with social justice and environmental protection as primary concerns. The devastating impact of COVID-19 for the most vulnerable members of our societies were in fact highly predictable, resulting from well-known defective governmental policies and austerity measures that have been subject to sustained critiques for many decades. A just and safe post-pandemic future should rest on recovery plans and aim to remedying disadvantage and exclusion while promoting health and well-being. Among other priorities, such plans should entail a deep reform of long-term care, access to housing, clean water, and other basic necessities for all, overhauling policing, criminal justice, and incarceration policies, guaranteeing just labor conditions, especially in sector employing the most marginalized individual, ending racial discrimination against Indigenous peoples and taking decolonization seriously, and acting to create a more equitable global order, notably through radical reforms of the world economy. Nothing short of such deep changes will protect our deeply interconnected communities and societies from future crises. Thank you very much.
So I've been asked to talk specifically about the section on work. So there is one of the 6 sections in the textbook that is entitled, "This Job is Gonna Kill Me, Working and COVID-19." So I'll be talking about some of the chapters in that section. It's called Section E in the book. And I thought I would start, not to be too self-centered, but start by talking about my own chapter for just a few minutes to set things in context and to kind of give you a picture about what it was like to co-edit this book along with our wonderful team in 8 weeks time. And it happened that while we were putting this all together, I was working at the time in a group home for adults with severe intellectual and physical disabilities. It's called Participation House in Markham. And it was an extraordinary experience. And 40 of the 42 residents who live in that group home were infected with COVID. 6 of them ended up dying. 57 out of 100 staff members were infected. And so there was a part of my brain that was focused on the academic discussions around COVID and vulnerability and working with our team to be able to get these chapters pulled together and edited. And then there was a part of my brain that was thinking about the real world context of suffering and death around me related to COVID. So I decided for my chapter that I would tell a little bit about that experience and describe the scenario in the context of Participation House. So it's a little bit of a different chapter, but I'm glad that I was supported by our team to write something that was a bit more in a narrative format, because I think it speaks to the fact that it is on the front lines that health policy finds both its inspiration and its testing ground. So the chapter does definitely relate to the topic of work. It shows the fact that so many of the staff, 90% of the staff, in fact, were forced to leave for a variety of reasons in the early days of the outbreak there, and the devastation that was a result of that, the sudden departures of the workforce. It also really exposed the hidden sectors of society. You know, the whole textbook focuses on this theme of vulnerability, and certainly one of the vulnerable sectors of society for which I think there's been actually continued minimal discussion is people with disabilities, and how they were one of many of the sectors who have been severely impacted by the pandemic. So you'll see in that chapter some themes around what it took to hire on an entirely new staff for a home in the context of a pandemic where long-term care facilities and other institutions were desperately trying to get enough staff to be able to care for people who were sick. And it certainly speaks to the impact that the pandemic has on people on the front lines of work. So with that, I want to go into a little bit more detail on some of the other chapters in the textbook, and particularly the ones that are focused on the workforce. And the one that I want to highlight in particular, because there are 5 chapters in this section, and I can't in 12 minutes go into great detail on every one of them, but they are fantastic, and I really encourage you to read them all. I learned so much by reading them myself. I want to focus on the first chapter, the opening chapter of the section on the workforce and COVID. And I want to give a shout out to the incredible authors. And I mean, this is just to give you a taste or a sampling, if you haven't had a chance to read the book yet, around the kind of quality of contributions that we were able to acquire for this book. And I actually think at least 2 of the 3 co-authors of this chapter are on the webinar today, so they can't speak up for themselves. So I want to give a big shout out to Pat Armstrong from York University, Hugh Armstrong from Carleton University, and Ivy Bourgault from the University of Ottawa. And they gave us the opening chapter for this section on privatization and COVID, a deadly combination for nursing homes. And this is an incredible overview, would not have been possible without the fact that these 3 co-authors have really a lifetime full of work that led up to the culmination of the contribution in this chapter. And in the chapter, they give a really expansive overview of the issue around privatization in nursing homes, and go through in some detail how that matter of privatization made residents and continues to make residents and workers more susceptible to COVID-19. So they discuss the shift over time of privatization and for-profit care delivery for older people, which I think has been discussed to a relatively significant extent in the media, but here's where you're going to find the really academic analysis of this particular topic. Of course, it's fairly widely known that the shift toward for-profit delivery has been promoted on multiple assumptions. Of course, the fact that many believe it to be more efficient. Theoretically, the argument for privatization, of course, looks at the fact that it may provide better quality theoretically because of competition, which I know some on the audience might challenge. But it also talks about the fact that privatization, of course, is encouraged as an opportunity to provide the necessary capital in a case where we know the cost associated with care for older people, and public investments have certainly not been sufficient for this need over time. They also really do a great job of pointing out how for-profit ownership, it's not as simple as I think the media tries to portray, that there's a bunch of long-term care homes that are not for profit and others that are for profit, but of course there's a tremendous amount of nuance involved. And the fact that even not-for-profit or government-owned homes often contract out a number of their services, so the lines of ownership or the forms of ownership are not as clear as one might think. So what ends up happening, and as I say, while I was reading these chapters and they were coming in, I was living this experience of seeing the very same things on the ground on the front lines, and seeing the fact that outsourcing of work means that many institutions, be they long-term care homes, group homes, and others, often don't hire their own therapists or nurses. What they will do instead is to contract individuals to provide these services through private agencies. And the private agencies actually take a significant proportion of the pay. So it's often public dollars that are supporting private agencies who then in turn provide the health workforce. Of course, one of the other things that happens in this sector is that there's a growing form of contracting that involves not just bringing on individuals in the workforce, but handing over entire portions of services to a for-profit company. So certainly this happens in the case of cleaning in a widespread manner, but also happens for dietary and laundry and security services. And some of these are provided by large international corporations. So this ends up being resulting in a real mix of staff, and the mix of staff have a variety of qualifications, and some are not paid, they're not all paid at the same rates. So what does this look like, and how does both the workforce these workforce issues affect COVID, but how in turn did the COVID pandemic affect a workforce like this one? So in this chapter, Armstrong and Burgo described really well what it looks like in a nursing home, and probably most of us have been there, but I think it took a pandemic for us to really understand what the issues are. So many, if not most residents require assistance to get in and out of bed, to have their toileting needs met, to be dressed and bathed, to be fed each day. Of course, many of them are wearing incontinence products and need to be moved sometimes by a mechanical lift or moved to prevent pressure ulcers. And all of this requires both an enormous amount of physical energy, but also technical skills, as well as a huge demand on the sort of social or psychological skills that this workforce requires. And then we impose on that already burdened workforce this pandemic, which and the need for following public health measures, wearing masks, trying to avoid close contact. And as you all can imagine, that ability to be able to have that kind of close personal contact is essential to the work, but makes it almost impossible to be able to do this from a 2-meter distance. But you know, I think it's really great to just recognize through the format of this textbook the amount of work that is put upon this labor force, who have this tremendous skill set that's not always acknowledged as a competency, but the ability to administer medications and figure out who can swallow and who can't swallow, and what will it take to make them swallow better and not choke, and how can we prevent them from spitting it up or getting angry. It's an incredible skill set that is really under-recognized. And most of this, as you know, falls then not to highly remunerated professionals, but falls to what we call in Ontario personal support workers, or in other provinces are called healthcare aides. And I would have to say that the other thing that I think this book points out well is that these nursing homes are called long-term care homes for a reason. And that's because despite the fact that people are sometimes closer to the end of life, they're certainly older persons that live in facilities like this, but they spend a long time in these homes, and staff get to know them. They become like family in a sense. And one of the things that happens is that when death occurs, there's an enormous amount of grief that takes place, and not always the appropriate time or circumstances to be able to grieve properly. So I encourage you to, I hope that's given you a bit of a taste for that chapter. It's really a remarkable piece of work. I just want to take the last minute or so that I have to let you know that in that chapter are 3 other really fantastic pieces of work. One by Katherine Lapel, who goes into issues around occupational health and safety and the rights of health workers who have been, from the data that we know so far, disproportionately affected in terms of the numbers of cases of COVID-19. There's also a really terrific chapter about providing patient care and the concept of whistleblowing by Ottawa's own Vanessa Grubin and Louise Bélanger-Hardy. And I absolutely encourage you to look at that issue in terms of the duty to provide care, and looking in more detail over this issue of personal support workers who are not self-regulated, and whether or not they should in fact be self-regulated. And then I can't stop without telling you about the last chapter in that section, written by a wonderful professor by the name of Sarah Berger-Richardson, who I think is Canada's, if not one of the world's, leading authorities on the agri-food sector. And I learned so much from her chapter, where she looks at the agri-food workforce, and the need, it calls for a compassionate approach to food systems, and how COVID-19 has really exposed vulnerabilities in that sector. So I hope I've encouraged all of you to go on home and get out the textbook and read some of the incredible pieces that are within it. Thank you very much.
Thank you so much. Thank you so much, Jane, that was an excellent presentation. We do have some questions, which is terrific. I just want to, before I start asking some of the questions, to let our participants know that you can ask your questions on the Q&A. I think I said the chat before, but please send them to the Q&A, and that's at the very bottom of your screen. If you don't see it at the bottom of your screen, just push your cursor all the way down, and that little, the little icons will pop up. Okay, so our first question to you, Jane. We've recently seen a racial reckoning of sorts for law enforcement, the justice system, and now journalism. In the past, the healthcare system has grappled with sporadic issues, but has never seen systematic efforts on this issue. What will it take for a similar reckoning to emerge for the healthcare system? And if so, what will it take to address the situation in a meaningful manner, and how might it unfold?
Okay, well, thanks very much, Melissa, for the question. It's a big one. And, you know, I'd love to know a little bit about the questioner and sort of the context that they're in, and sort of the implication that the racial reckoning is taking place in the legal and justice system and journalism. I think we all get our blinders on and sort of see what's happening in the world in which we live. So I would say, I hope it's good news to say that I think there's a very serious reckoning around racialization in the health sector as well, both from the perspective of academic healthcare, but also healthcare institutions. And there's an enormous need, I think, in every sector of society to look at systemic racism, colonialism, and other forms of oppression. So what will it take for a reckoning? I mean, I think it's a societal wide issue in terms of the amount of reckoning that has to take place. If I can maybe just bring it back to the context of the textbook and the things that we're talking about in COVID-19, I think we are only at the very beginning of understanding how racism has impacted the pandemic. There's a really interesting discussion that's arisen around race-based data, the inability to really provide a fulsome analysis of the impact of race on the pandemic, but early indications would suggest that by a wide margin, racialized individuals have been much more susceptible both to infection and to death. So, some of that is addressed in the textbook.
Super, thank you. This is a question from May. We have no for-profit or publicly funded long-term care homes. In Indigenous communities, we have to send elders to urban areas where they die alone. How do we encourage investments in long-term care on reserves in the North?
Well, thank you, May, for that question. I think it's a really good one, and you're absolutely right. Just like so many other issues, Indigenous peoples, and specifically First Nations on reserve, fall between the jurisdictional cracks of society. And we know that this has arisen as an issue when it comes to, for instance, the needs of children's health. But I would say that issues of older people's health is just as much of a challenge. And you're right, long-term care on reserve has been an area that provinces and the feds have argued over. The feds say long-term care is a provincial matter because it's healthcare delivery, and the provinces say that if it's an on reserve, we don't touch that, and healthcare is a federal issue. I am happy to say that the precedent has now been set. I am aware of at least 2 on reserve communities that have now had the go-ahead from the federal government and support to build long-term care facilities on reserve. I'm not sure whether this is the May that I know that might have put in this question, but I think everyone acknowledges that the trauma on individuals who went through a generation of being removed from their communities for residential schools are being definitely re-traumatized by the fact that they often do have to leave reserve to go into long-term care facilities. So it's an area of significant need, I think, in terms of your question. How do we encourage investments? I think others on the call will talk about the role of the federal government in in the pandemic in general and long-term care, and whether or not there should be ways to for the federal government to step into the long-term care space.
Okay, next question is from Karen Palmer. You use the word privatization, but as you point out, private can be for profit or not for profit. Isn't the real issue investor ownership than privatization per se, in that investor-owned facilities have a fiduciary responsibility to shareholders, not patients? Or is the issue public ownership versus private ownership, even if private, not for profit? Thank you, Karen.
That's what I love about this webinar. You get all these, you know, experts on these issues that are interacting. I think Karen's the one that probably knows far more about this than I do, but I think what Karen's question points out is the real nuances and how we can get ourselves tripped up often in terms of thinking about privatization not being actually the issue. As Karen well knows, a large proportion of healthcare delivery is private. But I think what I'd like to highlight is exactly the things that come through on that question. It's both the profit motivation, and therefore, you know, in my simplistic mind, I think about the fact that if you have an obligation to shareholders, as has been pointed out, there are incentives, of course, to cut costs. And, you know, we all know that human resources is one of the biggest cost drivers in this and many other areas. And the incentive to be able to minimize human resource costs is significant. And so I think, you know, the other thing, of course, she just talks about is the overall fiduciary responsibility to shareholders and how that issue of ownership. I think you're absolutely right. But what I will re-point out is, and I was just fascinated by this in the chapter by Armstrong and Bourgault, is that it's not as simple as we think. And so even as analysis comes in the months ahead around, you know, what's the difference in terms of the outcomes in long-term care homes, even within government-owned or not-for-profit homes, an enormous amount of the services have been delegated to for-profit institutions. So it's going to be take some pretty sophisticated analysis to be able to tease that apart.
He asked for Sophie or Jane. Thank you for your excellent contributions. COVID-19 is disproportionately affecting racialized women living in poverty and working in temporary and casual positions in long-term care. For example, nursing and PSWs. These careers are providing an essential role at a desperate time, filling in gaps left by full-time workers who are burnt out and taking leave with full pay. Both private agencies and government cite budgets stretched thin and an inability to offer anything better than temporary at the time. However, temporary and casual employees packages do not offer adequate support to new employees deploying to the front lines. So perhaps you might, I'll ask if you have a way to comment on this. Their employment lacks benefits and sick leave. How can we affect legislation to ensure at this time of crisis, all essential workers, including temporary and casual, who are deployed are given benefit packages that will adequately and cover the expenses of becoming that are coming due to their work? So Jane, would you like to take this one on first?
Sure. I'll take it on very briefly because I think it's going to be difficult to do justice to an in-depth question like that in just the few minutes that remain. And you've got three great other co-editors that need to come along. I will point, Chris, to the textbook, and particularly some of the chapters that discuss the rights of healthcare workers. But I think the questions are absolutely critical ones that speak to our lack of national standards, both the workforce standards, but also in terms of the expectations around the number of employees that should be given a burden of care in a long-term care facility like this, and whether or not the obligations are there to provide appropriate benefits and sick leave. All of these issues have been raised by the pandemic and brought to mind, but the question does remain whether we will see policymakers actually taking the necessary steps to enforce proper standards and monitor them.
Good morning, good afternoon, everyone. I am sitting in London, so we're heading into the evening, so I hope I got that right. So I want to firstly begin by saying thanks to many of you for making the time to come to this webinar, but also take a real sort of moment to acknowledge and thank all the people that were involved in producing this volume. This volume, as people have been saying, was produced in a very rapid way within 8 weeks, but it relied on so many people in order to their goodwill and their help, particularly people who've helped with the logistics of the project, but also the peer reviewers. Unlike us, we usually who get 4 weeks, they got 4 days, sometimes 2 days in order to turn some things around. So I really want to, and I can't name all the people involved, but I just want to sort of take a moment to say thanks to all of the people. So the section that I am speaking about today, and the one that I was tasked with shepherding, is the Global Health and Governance section, which is the section F. And so I want to begin by saying a couple of things. One is that each of these sections has a larger introductory chapter and then shorter pieces by the remaining chapter. So they're not all significantly huge tomes that you have to get through. And I think it's really helpful and really easy if you want to learn about a subject to just dip into one of these chapters and learn from some of the best academics in the world about that particular chapter. The Global Health chapter, the Global Health and Governance chapter, really, I think the really interesting part of this is that it decenters a lot of the different kinds of ways that we think about it. So for example, I think that the introductory chapter is, it's written by 2 senior UN professionals and academics based in Southeast Asia. And very rarely do you get an overview of global health, let alone global health and governance, from people who are not in North America or in Europe. And so it's a really important contribution, I think, because they're showing you that not every country failed, not every country did badly. There's actually a mixed sort of story here, and they sort of go through it from their perspective on what the factors seem to be that actually contributed to some countries doing well and other countries not doing well, and acting early and also making sure that there's trust between government and people seem to be 2 things that they significantly identify as being important for addressing pandemics, and perhaps sort of saying for the future pandemics come and any emergencies that countries and the world have to deal with. So there are also 6 other chapters, and I just want to, without giving out the plot for each of those chapters, I just want to kind of go through them so that you understand the diversity of the topics, but also after that, I want to give you kind of my overarching kind of view of how they all fit together. The second chapter in this section takes on a really interesting question about the possibility of what are the legal claims against the country of China, for example, as well as the World Health Organization for this pandemic. So if you remember, months ago, there was this really strong belief, political rhetoric, and perhaps a plausible case that some actors did not act as well as they should have in order to control this pandemic, and therefore enormous amounts of harm has been done. And so they'll go through the case of different kinds of claims about what that might look like and what that could be. The next chapter looks at this really important question, particularly for countries outside of the northern, western, wealthier hemisphere, that first ring of countries that were affected, which is that can you really have one policy made at a global institutional level that can be applied to all countries? This idea of does one size fits all? And this is particularly this idea of physical distancing. Now, you remember that we all call this social distancing, and somehow it got sort of caught up. I mean, what we really want is physical distancing, not social distancing, but it didn't matter because once the language got set, it just went. But then also this idea that what we want is we want to essentially shut down everything and we want to isolate people into their homes, and whether this actually was practicable for many people, but actually did it do more harm than good? And all of this really derives from this fundamental notion that you can have one kind of approach, particularly in science, to addressing a medical or scientific problem, that there's a general principle that you can apply and you can apply all over the world. So I encourage you to look at that in terms of thinking about that. And then the following chapters look at from Canada's own two legal scholars who look at the idea of national border closures and whether that is actually a necessary effort or whether it was actually a symbolic effort by countries, and what the questions are. And I think that that chapter perhaps is the only one or one of the few chapters which has graphs and charts, which I was very impressed at already in such a short time, already early on, that they were able to produce data. And I think that's a really important question for you to consider as to whether border closures are actually sort of effective in controlling infections inside as well as further transmitting infections to other countries as a result. And the last three, I think I'm going to bundle together because they deal with technology. So one chapter deals with algorithms and artificial intelligence and how we can make it much more accountable and ethical. This pandemic has become, I think, in so many different dimensions also, you know, as we say, it's unprecedented in this, unprecedented in that. Well, it's also very unprecedented in how we're using mobile technology in order to deal with this pandemic and what sort of algorithms are being used within these mobile technologies. And so this chapter really looks at what are the different kinds of principles that we need to address in trying to implement these kinds of technologies. And the last two chapters, one looks at innovation policy and IP and international trade laws and what this pandemic does in relation to these existing weaknesses, strengths, regimes, and what are the different ways that this raises further questions about the inadequacies and problems. And finally, the last chapter focuses on what everybody's talking about, which is essentially vaccines. And I learned a lot from this chapter because I had no idea that Canada was such a big player in the vaccine business, but apparently it is. But what they also tell is a very troubling story about how the incentives for making vaccines are used and abused and what really happens and what we really need to do to transform this situation, particularly for the COVID vaccine. And they sort of argue for making the COVID vaccine a public good and what sort of institutions and financing is required for such a prospect. So in order to take all these diverse things, and I want to be able to sew them into one or two overarching questions. And I would say this simply, one thing that I would ask you to do is that I ask you to think about this entire book about vulnerability as well as this global health chapter in terms of fear and narrowing your eyesight, right? So when you become afraid, you narrow your focus into a very, very small area. And I think that this section on global health as well as the book is asking us to not be driven by fear and actually expand your focus, because equity requires that you look much broader rather than just focus on the narrow sense. And so what I mean by that is, for example, health is global. We've been saying that for so long, but when this pandemic is struck and when people are afraid, they continually make the conversation about the local and the national. And we have to now more than ever recognize that our health, our determinants of our health are not only local, but they can be profoundly affected by global factors. So the more you narrow your scope to the local, you're going to be blindsided by something that happens on a global level. And so what we really need to do is not only respond globally, but we need to now think globally in the recovery, but also in the prevention of the future. And there is a second part of this, which is that in our narrow focus, what's also happening is that we are stopping learning from each other across different kinds of borders. And what I mean by that is that the lead authors basically say, you haven't been paying attention to what's happening in these other countries. They're doing quite well. What is it that you're not, why do you not want to look there? Why do you not want to acknowledge what they're doing? And so I think that there is this real sense that there's a dominant way of looking at the story about COVID that's sort of almost reflective only of certain countries rather than the entire picture. And so there's also, I think, in COVID, we've been focusing on healthcare, but not so much on public health. So there's this whole narrowing always of like, let's just focus on to ventilators rather than the social conditions that are determining vulnerability. And so how do you expand that scope as well? So I think that there's many different questions around fear narrowing the scope, but also the pandemic as being cover for people restricting the scope and the conversation to very narrow spaces and to very narrow areas as well. And so in my last sort of 2 minutes, I'd like to really talk about the last sort of 3 chapters and what that tells us, which is that technology, science, innovation is profoundly important in our ability to address this threat, in our ability to do recovery, in our ability to prevent the future ones. But what we have is a significant amount of self-interest that is at play in all of these different kinds of situations. Whether it's the self-interest about refusing to acknowledge other disciplines, refusing to acknowledge the lessons in other places, not wanting to be compared to other countries. But if we do not really address the fact that we need to move the scope away from self-interest and national interest to global interdependency, our solutions are going to be less effective and they're going to be narrow and they're going to be essentially making us more vulnerable rather than less. And I think that's the real kind of issue here, is that we need to be able to address self-interest throughout this whole recovery and technology and innovation problems in order to make ourselves resilient rather than increasing vulnerability within society, but also across the world. So with that, I want to thank you again for making time for joining us today. And I also want to thank all the authors who possibly are on the audience. And I'm sorry we couldn't get all of you and we couldn't talk all at the same time. And I hope that someday we're all going to be able to do this physically. And I thank you all.
All right. Well, good afternoon, everyone. And I reiterate the Sridhar's thanks to you for joining us this afternoon. I want to start out by giving you a little bit of the backdrop. Melissa's given us a bit of the story behind this book, and Jane as well. But I think it does help to sort of situate where we all were when this project first, the idea for this project first arose. So Colleen Flood approached us with this project idea really in the early days of the pandemic. I would say 4 weeks after everything had shut down. And for many of us, we were still at a point where we were wrapping our heads around being in lockdown, being at home. And it was a moment in which the major institutions of government had also shut down. And so the idea was to think about what were the major challenges that the government and our society were facing in this moment. And how could we as a collectivity of scholars play a role in that policy response, or at least try to help inform the policy response. And so that's where these chapters come from an early moment in the pandemic, and the hope to help inform some of these policy discussions. So many of the chapters, if you haven't had a chance to look at them, are really conversation starters. They're not detailed prescriptions for how all of the issues that have been raised should be addressed, but they were about trying to put on the table what the issues are, some various ways of approaching the complex issues that we were facing and are still facing, And so, you know, these conversations continue, and we're now at a moment where in Ontario, at least, we appear to be entering the second wave. And for me, it's really been interesting to see how some of these conversations that we started with the book have developed, and yet the ways in which these various chapters are still quite helpful in helping us think through the pandemic, and in particular, trying to avoid some of the very serious issues that Canada encountered early on. And so with that sort of backdrop, I want to talk today about one of the sections that I was responsible for editing rather. And that was the section of the book on public and private accountability. And so 4 weeks in, when we started thinking about the idea for this book, it was clear that the government was going to be making a lot of decisions very quickly. And my focus today will be on the federal government, but really the situation facing the provinces at the time was very similar, and the types of decisions facing First Nations across Canada. And so at the federal level, there was decision making already happening, obviously in very important public health decisions, but because of the economic impact of the lockdown, you also had the federal government introducing massive spending programs. You saw the federal government implementing a range of orders, regulations in order to respond to the various, very wide-ranging impacts of the pandemic. So the question is, and the question was, in those early stages of the pandemic where the situation is evolving very quickly, how do you keep a government accountable? And I think it's fair to say that even by sort of traditional emergency standards, this was a very difficult question. And so many of us are familiar. I come at this question from the public law space, and there's a very deep literature on how governments and public institutions respond in an emergency. And every emergency, of course, has its own dynamics. But here, in the context of this public health emergency, literally institutions were closed. Parliament was shuttered. The MPs had gone home to their ridings. I think the courts are right to say, and the Chief Justice of the Ontario courts, the Superior Courts, has said that the courts were never closed in Ontario. And that's likely technically true, but their work for a period had really reduced to a trickle until the courts found a way to pivot to online hearings of various sorts. And we've seen now that, in fact, there are still lots of matters that have not yet resumed. And so there's that additional challenge there. How do you use those traditional levers of accountability when the institutions themselves are not open? And so at the time that the contributors to this section were thinking through some of these issues, the challenges faced were very significant. And so there are a number of really interesting chapters in this section, from scholars writing from a public law perspective, from a public policy perspective, from a philosophical perspective, and also from the standpoint of scholars who are writing about corporate accountability as well. And here's where the kind of private accountability piece comes in. One of the features of the pandemic, both early on and now, was that it was clear that government couldn't do this on its own, that in order to marshal an effective response to COVID-19, the federal government was going to have to partner with private enterprise and with the private sector, whether that was to deliver PPE, for the logistics actually of transport of essential supplies. And now, of course, we know the latest frontier of this is with the development of a vaccine. And so whenever governments contract with the private sector or place responsibility in the private sector for delivering of services that have that public component, we know that there are also important accountability challenges. And so we have 2 chapters in this section which come at private accountability from 2 slightly different perspectives. One by my colleague, Professor Jennifer Quaid, who talks about what corporate law has to say about corporate accountability in a public health emergency. And then a chapter by my colleague, Marie-France Fortin, that talks about the possibility of bringing a private action or a civil suit against government actors. So using private law here, not toward the well, of course, toward the private sector, but then also against public institutions. And the fact that as it currently stands, our private laws provide very limited recourse in terms of keeping governments accountable. So in the time that I have remaining, what I'd like to do is to talk a little bit about the chapter that I contributed, which is situated in a cluster of chapters really that thinks about the accountability of public officials. And want to talk a bit about, in those early stages, what were the mechanisms that were being used to keep the federal government accountable, and the way that that has evolved since the beginning of the pandemic. Because I think it's fair to say that over the last 6 months, we have seen a shift in the sense that well, in some ways, but maybe not in others, but certainly in the sense that in the early days of the pandemic, you heard a lot about the importance of a Team Canada approach to the pandemic. And that, of course, is a slogan, but it's a slogan that had some weight behind it. And so there's some interesting research that was published in the Canadian in a Canadian political science journal by Eric Merkley and his co-authors, showing actually that in the early days of the pandemic response was not politicized at the federal level, in contrast to the situation in the US, where really from the start, the pandemic response has been highly politicized. And so this team's research shows that at least in the early days, you really had political parties operating with a very high degree of consensus and not attempting to make the pandemic response politicized. And you really saw that through the way that these major legislative initiatives found their way before Parliament. So what was happening was that the parties were getting together and negotiating the legislative package before it was introduced in Parliament. And there are real downsides to doing that, of course, right? That means everything's happening behind closed doors. And part of this is the result, the negotiation is partly happening because we're in a minority government situation. But what you did see even in the early days was a pretty high degree of cooperation, but also the opposition having some success in pushing back on measures that would have greatly increased executive power in the early stages of the pandemic. So they were behind the scenes able to negotiate some fairly important concessions. And so the lesson there is, just because you don't see it doesn't mean there's not some measure of accountability. But, you know, at the same time, the fact that so much of the early accountability mechanisms were happening sort of off stage, I think is also problematic. I just say that I think it's fair to characterize where we are now as being somewhat different, partly as a result of the WE scandal, but we see a much more active, vocal opposition, and I think we're just seeing much more visible sort of policy tussle now. We're beyond those early stages where it was, you know, Team Canada, we all need to respond in an emergency way. And so I think you're seeing many of those sort of more traditional democratic modes of accountability kicking in now, at a time where I think that accountability is welcome. So I'll just finish there.
Thank you very much, Melissa, and good afternoon, everybody. I'm so delighted to be here with my co-editors of Vulnerable, and as has been said, there are so many people to thank, but I'd just like to shout out a couple people. Stephen Binman, who has been invaluable in helping us get to this point, and Kelly White, an amazing JD student who works with us. Thank you very much. And another one special thing to Martine Lagacé, who's Associate VP Research at University of Ottawa, who really helped us make this a reality of publishing the whole thing in 8 short weeks. I'm also really delighted to be speaking on the topic of civil liberties today, and I'm actually going to do more of a substantive dive on the topic, particularly since today, with Vanessa MacDonnell, who was just speaking, and my colleagues Brian Thomas and Kuman and Wilson, we just released a new report with the Royal Society of Canada on the topic, which you can find in French and English on their website. So first I'm going to speak about how the courts think about civil liberties in the context of COVID-19, and then I'm going to talk about how public health decision makers can and should think about civil rights issues in the context of the COVID-19 pandemic. So first of all, on the court side, the takeaway message I want to give you today is that a claim of civil rights is not necessarily a trump card, and it is possible for governments to defend these kinds of these kinds of claims. So first of all, what are civil rights? Generally, these are things that we consider so fundamental that government shouldn't be able to limit our ability to enjoy them. For example, freedom of speech, freedom of religion, freedom of association, mobility rights, and privacy rights. But not all civil liberties amount to a civil right, or what we think of as a civil liberty. So for example, the right not to wear a mask, it doesn't mean that that is a civil right protected in law. But some ideas of civil liberties may be protected as rights, for example, under the Canadian Charter of Rights and Freedoms. So civil rights challenges that we have seen to date include a challenge to provinces shutting down their borders to non-residents. For example, in Newfoundland, a provincial measure that was actually upheld last week by the courts. Challenges to hospitals saying no visitors. Challenges to incarceration of prisoners when there are concerns that there are inadequate protection measures being taken. And challenges on the grounds of privacy, where the Ontario government was permitting the police to access the COVID-19 database for the purposes of enforcement. And I think sometimes when there's a discussion about civil rights in the media, or generally, there's sort of a sense that civil rights must or will always triumph against a claim that a precautionary measure is needed. But as I've mentioned, in fact, in Canadian law, governments can defend what might otherwise be infringements of civil rights on the grounds that the government's response in all the circumstances is reasonable and proportionate. And so, for example, such justification is possible pursuant to Section 1 of the Canadian Charter of Rights and Freedoms, which says that charter rights are subject to, and I quote, such reasonable limits prescribed by law as can be demonstrably justified in a free and democratic society. And now over time, that's become a term of art with a very detailed test laid out in what's known as the Oakes case. But in application of this test, it's vitally important to realize that the context really matters. So in the context of a global pandemic, particularly in the early stages of the pandemic, where there's very little evidence upon which to act, and yet it is clear that action is required because of the enormous risk to human health, then the courts will be much more forgiving of governments and their choices in a Section 1 analysis. But it's important for governments to realize that they can't pick a rights infringing option, for example, restricting travel to and from a province, and then just sit back on their heels Over time, if the evidence changes and it turns out there are other less rights infringing means to achieve the objective of quelling COVID-19, they must at least carefully analyze whether that couldn't be a real option. So as the evidence changes, governments are required to bring evidence to support their actions that might infringe upon civil liberties like privacy, freedom of religion, or freedom of association. So for example, a blanket ban on religious gatherings probably wouldn't hold up if it was possible for the gathering to be outside, for people to be socially distanced, to wear masks, and so on. So government and public health decision makers can't just sit back on their heels. They must respond to the evidence. And sometimes, though, they might be reluctant to do so because of the pushback that they get from people who are science skeptics and see any change in policy as indicative of some grand conspiracy instead of what it normally is, namely that government is doing quite a good job responding to new evidence. And here you might take, for example, the brouhaha with Dr. Theresa Tam and changing guidance regarding mask wearing. So now the important point though is even with evolving evidence, so as the evidence changes about what's possible to be done to quell the spread of COVID-19, courts will be very sympathetic to the fact that governments are wrestling with what we call polycentric problems, and that different concerns have to be weighed. On the one hand, you know, the interests of people who are concerned about their civil liberties being affected, but on the other hand, the interests of oftentimes very vulnerable populations, frail elderly, immunocompromised, and others who will be affected by the spread of COVID-19. So again, the court is not going to rush in to superimpose what it thinks is the best path forward in terms of policy choices, but likely will only ask if the path forward is a reasonable one, even when civil rights are limited. Now, one issue, as Sophie mentioned and Sridhar mentioned too, I think, that has come up in terms of civil liberties is the problem of discriminatory enforcement. So concerns that the police or enforcement authorities are applying laws or requirements disproportionately against Black Canadians, Indigenous peoples, and the homeless. And this, I think, is a problem in our rights protection framework, because it may be true that a certain individual is breaking a law or a regulation or a protocol, and so a court is likely to concur with the enforcement official. But a court looking at a single individual misses out on the larger systemic problems of under or over enforcement. Okay, so that's the court side. Now I'm going to turn briefly to look at public health decision making. And to note at first that they start from a frame of what is known as the precautionary principle. And many of you are probably familiar with this concept, but in a nutshell, it basically says that even when there is very little evidence or even no evidence of the scale of the risk or what is causing the risk, that the risk itself is so great, for example, global warming or millions of deaths in a population, that steps must be taken. And you can see that this is the kind of frame that infectious disease experts would likely want to start from. But even here, over time, this idea of the precautionary principle has evolved, because in application, public health officials have realized that its single-minded application can result in other public health harms and problems. And as Sridhar and others have mentioned, imposing lockdowns causes, sometimes what's known as collateral damage, and particularly harms to vulnerable populations, domestic violence, lack of schooling opportunities for poorer kids, mental health issues for people in overcrowded and substandard housing. So a true public health response must consider both sides of this issue. And so what we have seen, I think, is in the evolution of the understanding of the precautionary principle from a public health response, is that there's a lot of similarities with a Section 1 analysis. For example, the European Commission's guidance on the precautionary principles incorporates various sub-principles which echo Charter law. including principles of proportionality, non-discrimination, and consistencies with measures taken in areas where there is scientific data. So I think we're starting to see that there's often sort of this divide in public health law between civil liberties and public health. And I think increasingly we're realizing that in fact there's a great deal more overlap. So let me finish with 5 takeaways so we can get to the conversation very quickly. First, rights are not trumps, civil rights are not trumps, and government can defend rights limiting moves, and the courts will be relatively sympathetic in the context of a pandemic, particularly in the early stages. Second, as evidence evolved, governments must move. If there are other ways to quell the pandemic without infringing civil rights, like the right to mobility, religion, freedom of association, they need to be examined seriously and taken if possible. Third, the evidentiary burden here lies on governments to justify their actions and not on civil rights claimants. But nonetheless, governments are entitled to take public health objectives seriously. It's evidence that the decision to restore civil liberties, if you wish, in other countries, most notably the United States, has actually harmed rights and the fight against COVID-19 in the long run, since they've had to reintroduce even more draconian measures along with the second wave. Fourth, from a public health perspective, a singular myopic focus on quelling an infectious disease like COVID-19 isn't appropriate, that the collateral damage, the other public health effects must be considered as well. And then fifth, and finally, we must consider in our assessment of COVID-19 responses, how laws are enforced on the ground, and specifically whether marginalized populations are disproportionately burdened, whether through discriminatory enforcement or the sheer improbability of complying with regulations that assumes people can afford protective equipment or have a home in which they can safely shelter. And as I've mentioned, it doesn't seem to us that likely that the courts will be an effective buttress against these concerns. And so it's likely going to fall to civil society to track these issues and press for solutions. And at the same time, though, this is again on the one side and on the other side. On the other side, it's important to recognize that marginalized populations have been disproportionately affected by the pandemic itself, with higher rates of infection and mortality rates amongst specific demographic groups, for example, Black Canadians. And as such, those who argue that their civil rights are being infringed are creating risks for these vulnerable populations. So it's been a great pleasure to be part of the webinar today. I want to give a shout out to all the fabulous chapters in Section C, Civil Liberties. Go Section C. It's also the start of my own name, C for Colleen, so you won't forget it. Go and read those chapters, and there's some terrific things in there about immunity passports, about contact tracing apps, about the homeless folks, and shutting down of borders. Thanks very much, Melissa.
First question is coming from Alison Paprika, and she's focused on some of the investments that governments have made in response to COVID. When and how investments in CERB and other programs increase or decrease in inequities. Is this a mechanism, or can we be thinking about these investments as a way forward for basic income as a policy? So looking at CERB and other types of investments, can these be levered to consider as a pathway for basic income? And perhaps maybe I'm going to start picking on people. Sophie, could I get you to start perhaps thinking and reflecting on some of these policies and how they might be used in next steps, and then we could get everyone to comment as well. But I'll be picking on you.
Yeah, I'll take a shot at it. So I think that yes, and not only the investment that have been made, but all the people that are in the shadow of those who are forgotten by those measures. So there's been massive investments that shows that we actually can do it. But lots of people are also forgotten, thinking about independent workers and so on. So it's very hard to have specific measures or targeted measures that would be all inclusive and make sure that everyone, and especially people with extreme low income, can also benefit from the leverage. So I think that not only the amount that have been in the different programs that have been put up, but also the critique of those programs also show that perhaps universal basic income might be the way to go in order to ensure greater equity and equality within our societies, and making sure that, and being more simple in some ways to administer, and not putting anyone in the shadow of those, and making everyone benefit from those. But I see Vanessa who's nodding, so I will.
I just jump in there to say that, yeah, one of the interesting things that we've seen actually from the Senate is that there's been a real push from, there's a majority of senators, or I think it's a majority, but it's over 50 senators at last count, who have gotten behind the proposal of transitioning the CERB into a universal basic income. And since the Senate was reformed a few years ago, we've seen, the Senate now is far more nonpartisan. And so is a real diversity of senators now, and it's been quite interesting to see a number of senators coalesce behind this plan and actively advance it, and try to influence the government's policies in this realm. So I think certainly we saw from the speech from the throne this week that the CERB is going to be extended. And I think in light of the rise of the second wave, we've seen the federal government for the moment hold off on announcing any transformational recovery plans, partly because I think their sense is we're not out of the woods yet. We really need to focus on COVID wave 2 before we think about what happens after COVID. So for the moment, we're seeing an extension of some of those major packages that were announced at the outset of the pandemic, but there's certainly a very strong call for those programs to be rolled into something permanent. And the truth is, it's very difficult once you've created a situation where you are providing people with a monthly lump sum that really does make a difference in terms of their quality of life. It's really hard to imagine how you then roll that back and say that a fraction of that amount monthly is adequate, when we know that those amounts are just not sufficient to ensure a basic standard of living.
Great, thank you. Colleen.
Yeah, I just wanted to make 2 comments on this. One is that, poverty is a huge risk factor for COVID-19 and for other major public health issues, right? As a social determinant of health, poverty is probably the greatest determinant. And so things like a basic income attend to this. So in a way, it's investing in our future health and prosperity by thinking about these options. But whatever it is we're doing, we need to attend to the poverty gap. But I just want to reiterate Sridhar's larger point, and the point that we make in the book collectively, that we also must look up and out at the same time. At the same time as we're attending to local poverty, we must also think about our global interconnectedness and responsibilities, and we need to make sure we make investments in that space as well. So I just want to make sure we don't get too down that. And by saying that, I don't mean to say you do one and not the other. No, we have to do both, but they both must be at the same plane.
Super, thank you. And that's a good transition to another question that's emerged. Sridhar, one of the questions is looking at not so much what we're doing outwardly, but why. The question of why are we not taking best practices, effective solutions from other jurisdictions and applying them to our own jurisdiction. So the question person was asking about the why. Is it Eurocentrism? Is it something else? Has that been examined around this lack of sharing and using best practices elsewhere?
I think that's the $1,000,000 question. You know, why would we not be looking for the answer to our problems anywhere and everywhere to do so? I mean, I don't know the true answer to it. I just find it profoundly confusing as to why we would not be looking anywhere that we could for the best solution to our problems. I will give you a couple of ideas about why it's happening. One is that we have to think about the way, and I think this pandemic has made clear, about the way information travels and knowledge is produced. And so it travels usually in one direction and usually originates in certain places. And it's very hard, for example, if you think about even knowledge production, scientific knowledge production. I just did an interview with the editor of BMJ Global Health. And it's a fantastic Nigerian doctor named Shea Abimbola, who's based in Sydney. And we had a whole conversation about what he's experienced over the last 7 months as editor, what he's seen come in and what he's seen getting sort of offered as solutions and discussion. And it was a really enlightening conversation. But by far, what we know is that scientific knowledge is produced in the big academic machinery of North America and to some extent Europe. And it has the perspectives of certain people who only ask certain questions and who rarely think about looking at the solution somewhere else. And so this has been true for health policy for a long time. If we think about health inequalities and the fact that there's so many other countries that have better health inequalities, but we don't look to them for what kind of solutions that they have. It's very much like, well, we'll just look internally to see which state, which region does better than another, and we'll compare those two things. So there is, I would think, some sort of bias towards one's own self and what's familiar or within their own borders. I would say that's one. The second thing is that I think that there is actually something profoundly at play here, which is that within Canada, within the United States, within the UK, there is just a denial of the extent of failure, that somehow we have not done badly. And therefore, why would we look somewhere else to some Southeast Asian country? It's actually, we seem to be doing better than our competitors, our equals, which is, USA and UK. And so that seems to be another bias as well. I mean, I could talk for hours about lots of different examples, but for example, I find it astounding that journalists will not call the world-renowned expert in London, UK, if they can call someone lesser well-known next door or someone like that. And I was like, phones don't cost anything anymore to make a phone call. Why are you not calling people on the other side of the world if they're the leading expert? So that I also don't understand. But what this does, and I'm sorry I'm taking up time, but what this does is that it puts us at a disadvantage, because if we aren't looking for the best solutions anywhere in the world, that means that we're actually allowing our vulnerability and our sort of problems to persist. So I wouldn't care where the solution is. I would look for the best solution, but nevertheless, we're sort of not. So I would say that those are the particular couple of descriptions and the way and why it's happening, but a more profound value question about what are the values that do that, I leave that open for people to discuss.
Thank you. Any other comments? I'm going to change tactic to quite a different question now from Dorina. She was reflecting on the reliance and use of technology to stay connected, whether it be to get groceries, to get healthcare. Education is another one, online learning for our children and our students. And to what extent should digital access be a determinant of health and met for all Canadians? And in other words, access to the internet as a human right, digital literacy, those sorts of things. And any comments or feedback about that? Would anyone like to start?
I'll say something.
Super, thank you.
Melissa. I think yes, obviously with a move to all things digital, you know, there's certainly a digital divide between have and have not Canadians, and this one is not just on socioeconomic status, but also rural versus urban as well. So, you know, much greater problems with connectivity for people who are living in rural areas in the north of Canada. I think all of the things that she said, the trouble is, you know, when we look at this from a legal from a legal issue, she's saying, you know, should it be a human right? The problem in the Canadian modality is, if you're thinking then that, well, could I bring some sort of court challenge, you know, to argue that I should be able to have access to X, Y, or Z? That is a much more difficult question. So when I was talking about civil liberties, for example, these are what we call in constitutional language kind of negative rights, because I'm not actually asking the government to pay for anything in particular, but I'm asking them to get the hell out of the way so I can do whatever it is that I would normally do. But when you're actually starting to ask governments to pay for something, whether it's healthcare or education, then your chances of bringing a successful court challenge, they're much more difficult than even what I was discussing before, because the courts have been reluctant, for example, to recognize a freestanding right to healthcare. It may come in at various points, but it's difficult to argue for it from a freestanding perspective. And so I suspect the same would be for access to digital support. So I think your question is an interesting one, but from a legal perspective at the moment, it's a bit of a not really happening anytime soon.
Any other comments? Yes, please go ahead. Oh,
I
sorry.
think I heard.
Sorry.
I think I heard.
You can't tell who I'm looking at.
Oh, sorry. Who are you looking at?
You. Go ahead,
Okay.
please.
So I think the question was about access to technology and the internet and whether that should be considered to be sort of more basic. I just want to point this out that, you know, one of the problems with this idea of we're all going to physically distance into our homes assumed that people had, you know, separate rooms for themselves and to work here and work there, or that they had cash savings so they could stock up on food for weeks on end. And the other thing that they assume, or this assumes, is that you're able to do all this other kind of work and communicate because you have internet. And I think that this has been one of the, I don't know how many times I should say this or who needs to say it, is that, you know, policies geared towards middle classes create a lot of problems for poor people and marginal, right? So the politicians imagine that there's this house with, you know, certain number of people and certain number of rooms and certain kinds of basic amenities, and that policy is stuff. So somebody yesterday was talking about the 70-kilo man as being the standard for medical research. And I think policymakers also imagine that there's this kind of family domestic situation and we're going to make policies for them. So why I'm saying this is that, you know, whether it be in Canada, in the richest countries, or in poorest countries, that standard of what you're assuming, either ensure that everybody has that standard, or start thinking about what the situation is for the worst off and then build your policy up from that kind of thing. A last point is that when we think about Colleen's point about poverty globally, not just domestically, one of the things that's always interesting and a problem when we think about doing global health in other places in poor countries is we always think about minimum packages. What is the minimum health care that they can have in order for them to achieve something? And so, for example, surgery is never included in that minimum package because it's too complicated and it's not enough and there's no big bang for the buck. And that kind of minimum threshold thinking, it's also something that you can imagine someone saying, well, the internet, why do they need the internet, right? Well, the internet is shown to us to be life-saving, if not in order to earn an income. So we really need to think about the role of technology in having a minimally decent life for people around the world, not just in middle-class Canada, and really kind of make an argument as like, our notion of what is a decent, flourishing life in the modern world, in the 21st century, has technology in it. So let's start to reconceptualize what that means in terms of basic rights to different kinds of goods and services. Thanks.
Thank you. This is another question that is looking at, it's reflecting some of the presentations that all of you made about having to make choices and prioritizing, and the ethical framework around prioritizing certain things and the policies that can inform that. This is related to the investments made to scale up human resources and resources overall for the healthcare system. But in many jurisdictions, we're not seeing that same continued or enhanced investment for public health units, for the workforce in public health as it relates to tracing, health promotion work, all of those sorts of things, increasing capacity for screening even in those components. So the question is how can this discussion be better had? How do these priorities get sorted and of that nature? So how would you recommend that we start generating more discussion on this? Are there policy levers that can be used, etc.?
Melissa, is the question in the context right in the middle of COVID-19, or is this more ex ante? Why aren't there more investments in public health?
Well, I think the question, this is from Yupeng, it was within the context of COVID-19 and the scale up of certain sectors where they're making investments at the expense of other sectors. So in healthcare, in hospitals at the expense of public health units, if I'm understanding the question correctly, that the choices of where scale up and investments are being made, how are those happening, and how can we shift the discourse so that there is discussion on other areas where investments and policies could be enhanced, and in this case around public health units and public health unit activities.
Okay. So I'll take a first stab at this. So just in terms of, the governance problem per se in healthcare is that we have fragmented, siloed approach to many things. So individual hospitals doing their own thing, individual physicians doing their own thing, individual public health units doing their own thing. So it's very hard in the Canadian context to have a whole of systems approach. And normally, we sort of bubble along and we have enough money to burn, so we don't really feel it too much. But when in the middle of a pandemic, suddenly all the chickens come home to roost and we see all these problems. We don't have the capacity to be fragmented and siloed at this point. But I think our governance structures just aren't set up for a whole of systems approach. So, people are wondering why there are 7-hour lineups for public health testing and these kinds of things, COVID testing. When you don't have a joined up system, this is what you get. But I think it goes back to an earlier problem, which is just a lack of investment in public health per se. And I think here, this is a problem of public health is an enormous thing. It's everything in a handbasket. It's not just to protect against infectious disease, but it's also, safe sex, well eating, all these kinds of things. And I think there's various kind of political views about the merits or otherwise of investment in it. I think if we're just talking about preventing infectious disease, there'd be more political buy-in for that. But it's all bundled in together with other things from which there are very different perspectives on the right and the left about the merits or otherwise of investing in it. So this is just my personal opinion about why it's difficult to get buy-in for funding for public health. I think everyone now thinks, oh my goodness, we should be investing in public health. But what they really mean is preventing infectious disease, not necessarily all the other good things around the social determinants of health and public health that we think of. And I think that's why you've seen since SARS, you know, despite a mea culpa, what the hell went on at SARS for Canada, really a diminishment of focus on public health since then, because it is in the minds of some associated with more lefty kinds of investments that, you know, groups don't necessarily want to make. So I think that's the basic problem. For me, I think we should actually commit to a certain percentage of our healthcare budget should go to public health. So as we make investments in healthcare, that X%, you know, a good bumper crop goes to public health, and that is legislated. That's how I would see it, because I think it's always going to be the orphan Annie, you know, the little kid, the baby sibling who's going to miss out because of the gobble monster of healthcare, which is immediate and now, and not 10 or 15 years or 20 years down the track. So,
Thank you. So I am recognizing where we are with time. I'm sorry, we're not going to be able to get to all of the questions, so maybe you can email, but I'm going to end with one, and I'm going to ask each of the speakers to maybe give a 20-second, 15-second sort of thought to this. So your book is published. We're now entering the second wave. A few months have passed. What do you think the major developments or areas of public policy that will need to be focused on, that maybe you didn't anticipate, that you want to cover in the next edition when you do 8 weeks again? So maybe I'll start. Colleen, why don't I start with you, since you were the last speaker, and we'll go backwards. Your 15-second comment to that.
Well, you know, we had a great deal of worry about what to include and not include, and one obvious gap that we had was around education. We really wished we could have, we really had a whole volume on education. And we wished we could have had a particular chapter on the issue of Black Canadians and where they are situated in all of this. Looking forward, I think, you know, you're going to be able to write a whole book about the distribution of vaccines and how vaccines are produced, allocated, and who gets what and when. I think this is going to be an ongoing issue for many years that we are going to really have to wrestle with. And so Sridhar is going to be on speed dial from here on in.
Super, thanks. Vanessa, any other comment to that?
Very quickly, I'll just say, I think we were speculating in the early days of the pandemic about whether this would end up being an important turning point for government in terms of policy. And I think 6 months on, what we are seeing coming out of the federal government for sure is, if not now, certainly down the road, that this government, if they continue in power, do intend to use the COVID pandemic as an opportunity to implement some significant changes in terms of the social safety net, perhaps in the environmental sphere. So without being too optimistic, I think that we saw an opportunity here for governments to address some very long-standing inequalities that are baked into our policy frameworks. And there are signals that government may respond in significant ways to some of those inequalities. I'm sure we won't be fully satisfied, but I think we will see changes that will come out of the pandemic experience. Super.
A few seconds left. Sridhar, any additional thoughts?
Just that, you know, this is by far and means not over. We just wrote a book on the first section of it, and that was just the starting of it so that people could think about it while they're talking and implementing. We now have a second wave. I want to also point out that what's happening at the international level is beyond, I don't know what the word is to use, is that the rhetoric and the reality could not be further away. In terms of the secrecy, the lack of transparency in the international institutions, and the few people that seem to be making all the decisions are enormous with global implications. And so we really would pay much more attention to that and try to figure out what's going on and what the issues are. And I think that's something that we need to pay attention to.
Excellent. Last very few seconds to Sophie. Any
to build on both Colleen and Sridhar, I think like looking at issues of Black Canadians, but also recent immigrant and immigrant status and this issue of data, I think we really need to go deeper into how we get data, which kind of data, and how we use data in order to refine our understanding of vulnerabilities. So that would be one of my priority. And the other one would be probably environmental sustainability and environmental protection. So as governments make choice for recovery, we've seen cutbacks in environmental protection, including in environmental impact assessments that are cut short, and other cutbacks that might cost us a lot in public health and inequality in the future if we don't pay attention to environmental protection. So I would probably want to focus on this in the next book.
Wonderful, thank you. So seeing the time, I'd like to thank everybody for attending today's webinar. Congratulations to the co-editors, to all the contributors, and to the audience who participated and asked very, very insightful questions. Thank you so much. We very much appreciate your participation, and we hope you enjoy reading the book. It's excellent. I've really enjoyed reading it. Take care.
Thank you very much.
Merci.